Order, order, good morning. This is the Health and Social Care Select Committee for the second day in a row. We just cannot get enough. This is our public evidence session Wednesday morning, May the 8th. As part of our future cancer inquiry, it's an appendum to that. We are today looking at NICE Medicine's appraisal process. We're currently drafting our report on future cancer, which is the culmination of a long and complex inquiry that we've done into that subject. Today we're going to explore NICE's approach to appraising medicines for use in the NHS in England, but obviously with implications across the United Kingdom, with a particular focus on NICE's revised evaluation system, which came into effect 2 years ago. The aim of the session for those watching and for those listening is to understand the implications of these changes, notably the introduction of what's called the severity modifier on novel cancer medicines. This sounds complex. It is. But there are real people's lives at stake here. So this is an opportunity for our cross-party committee to explore the system through the high-profile cases that there have been, not least Enhertu, which is a breast cancer drug, which we will be discussing throughout the session. But the session is not specifically about that. It is about NICE Medicine's appraisal with various examples. We have 3 panels, and we have to crack on because we have a fairly tight day here, including Prime Minister's questions downstairs, which members need to get to. Our first panel is in place, and that is David Brocklehurst, who's the head of Oncology at AstraZeneca UK. Hello. And Haran Maheson, who is the Vice President of Oncology at Daiichi Sankyo UK. Thank you very much for coming. I will kick off, if that's okay, and ask you, you said in your note to us, from a joint note from you, that you are, and I quote, keen to explain as transparently as possible why the outcome in respect of Enhertu has happened. So, broadening it out, as I said that we want to try and do, why do you think NICE reached the decision not to recommend Enhertu for use on the NHS in England? And what do you think that decision says about the state and the status of the appraisal process for cancer medicines in England today? Let's start with you, Mr. Brocklehurst.
Sure, yeah, thank you so much for the question. Thank you, Chair, thank you, Committee, for convening this session. It's such a critical topic, or critical topics actually. First, as you mentioned, is the pressing issue of the recent NICE appraisal of Enhertu for HER2-low metastatic breast cancer. Clearly, we're highly disappointed with that outcome, and it's intertwined, as you rightly recognise, with the recent change in NICE methods and the introduction of the severity modifier system, which has been central to this appraisal. And we do. How would you explain, bearing in mind that there are people watching this who may not be, literally living and breathing this every day in terms of the details of NICE severity modifier? How would you explain, in the most layman's terms, what the severity modifier does or attempts to do? Sure. So it's essentially an algorithm used by NICE within their appraisals for new medicines to assess the severity of different diseases and classifies them as high severity, medium severity, or not severe, and that determines essentially the weighting and the outcomes of the appraisal, and essentially the willingness to pay for new medicines in those settings. They were introduced in 2022, and replacing what was previously called an end-of-life modifier, which was predominantly used for metastatic cancer. The intent of the severity modifier was good because it intended to enable more conditions beyond cancer to benefit from a modifier. Unfortunately, in reality, NICE have acknowledged this themselves in recent board papers, that the utilisation of the modifiers has been a little bit lower than expected, and that's why really we believe that the Enhertu case resulted in a negative outcome, and that's why we believe that modifier system needs to be evolved so that we don't end up in the same situation with future treatments.
Okay, so what do you think then it says about the status of the appraisal process?
So, I mean, like I said, I think the intentions were good. In reality, what has happened because of that underutilisation is that there's been a kind of a de facto degradation of willingness to pay for new cancer treatments without the broader benefit that was envisioned. So there needs to be an adjustment to the qualification criteria for these modifiers.
Okay. Mr. Maheson, what do you think in answer to my initial question?
I would agree with Mr. Brocklehurst's comments. I think it's important to state as well that up until 2022, for over a dozen years, NICE had a special criteria, a special funding mechanism to recognise the severity of disease, and in particular with metastatic breast cancer, the fact that patients have a relatively short life expectancy. So essentially, metastatic breast cancer was considered to be a disease of high severity. If we fast forward to 2022, NICE evolved their methodology with good intent, as David said. However, one of the impacts of those changes in methodologies has been that diseases are essentially segmented according to severity using this algorithm. And metastatic breast cancer, a disease that essentially is terminal and has a very, very short life expectancy, has been downgraded from being a disease of high severity to being a disease of medium severity. And I think anyone who's a patient or a carer or anyone who's signed the petition that breast cancer now have in place at the moment, 240,000 signatures, would argue that looking after a patient with metastatic disease or suffering from it, it's certainly not a disease of medium severity. It's a disease that's highly severe, as NICE recognised up until 2022, and as Scotland still recognised to this day.
And what do you think the likelihood is of a change? Because this is only barely 2 years old, so logic would suggest that these are early days, and there are many more examples and case law, for want of a better expression, to flow under the bridge. So what do you think the chances are of a change?
Well, Mr. Chairman, I think it's fair to say that NICE have recognised that there's a challenge with the implementation of the severity modifier. Indeed, at committee meetings, they've mentioned that there's a challenge with its utilisation, and that can be borne out in terms of the number of appraisals that have taken place since the severity modifier was introduced in around January 2022. Of the 39 or so appraisals that have taken place, only two out of 39 have reached the highest level of severity. Everything else has essentially been downgraded to either medium or non-severe in terms of disease state. And it's important to recognise that. The severity modifier, first of all, recognises the disease state rather than the product. The product is then essentially dovetailed into that disease state.
Yeah, that makes sense, yeah. And it's important to say for those watching outside is that NICE will be talking to the committee this morning as well, so we're not talking about them without them. No decision about me without me, as they say. Mr. Brocklehurst, what do you think the chances of a change are?
So, I mean, Haran rightly mentioned that NICE have recognised the underutilisation. They've committed to a review of the severity modifiers within the 24-25 year, and we welcome that. I think so in that sense, we'll have to wait and see the outcome. What we would like is that there's really some urgency around the higher severity modifier in the short term. The reality now for this case with Enhertu is that we have 4 months from Wednesday next week in order to have an evolution in the system that would allow us to utilise what's called the rapid review process, which really is the only way that we could see Enhertu being made available for this patient population.
So why have you decided, correct me if I'm wrong, not to launch an appeal against the decision?
So, and the appeal process with NICE really is just to appeal whether the methods have been applied appropriately. Right. And so we chose not to...
Which they have.
Which they have, absolutely. So, which is why we chose not to appeal. We recognised and we commend Breast Cancer Now and the UK Breast Cancer Group for appealing, but we didn't feel that was likely. And really, in order for the medicine to be available for the patients that need it, it's going to require a change in the methods.
Which is why you're here, because you're asking us as the scrutiny committee of
Absolutely.
The health and social care sector to scrutinise whether the system is not that the system's worked correctly, because it clearly has, but you're asking us to scrutinise whether the system is fit for purpose in this instance. Okay. And then just finally from me, and I'll bring in Rachel Maskell, what do you think, because we were, obviously, as I said at the start, we're writing our report at the moment on our future cancer inquiry, which this is clearly very much future cancer. What would you say, if you were writing recommendations for that report, what would you recommend to us?
So, I think two things. So thank you for the question. You rightly said it's quite a technical, complex issue. So the first answer and the first thing I would recommend is quite a technical answer, so forgive that. But ultimately we would recommend an evolution to the qualification criteria for the severity modifier, Quite simply, we would like to see, and based on our analysis, we believe that if you reduce what's called the proportional shortfall threshold for the higher modifier from 95% to 90%, that would enable all medicines that previously would have qualified for the end-of-life criteria to also benefit from the 1.7 modifier. So that would essentially remove the unintended inequity that's been created through the methods change and ensure that there's no kind of retrograde step for cancer patients. And that can happen, that's the first thing, which can happen maybe quickly, whilst the second thing is ongoing, which is the fuller review of the methods which NICE have already committed to.
I think, people listening, Mr. Maheson, will think, okay, 24-25 review, but bluntly, there'll be people listening who don't have 24-25. And therefore, a longer-term solution maybe, but a short-term solution would be qualifications to the security modifier threshold. Does that make sense?
I would agree with David's comments. Essentially, increasing the bandwidth for qualification for the different grades of severity, in this case, high severity.
Okay, that makes sense. Good start. Rachel Maskell, over to you.
Thank you ever so much, Chair, and thanks very much for coming in today. If I can start by just asking about the efficacy. Clearly, NICE recognise the efficacy of the drug we're talking about in this instance, but also their mechanisms seem robust in that area. So the analysis is around cost, essentially, and how that comes together. So in the light of the modifier which they've brought in, should metastasized disease automatically be included in high severity? Should that just be a criteria which is recognised, and then to move those drugs into that category in order to reach thresholds? Is that the solution? If I'll start with you, yes.
Thank you. Up until 2022, that was actually the case, whereby metastatic diseases, lung cancer, breast cancer, were classified as diseases of high severity. So by de facto, all treatments, or most treatments for those conditions, would be within that banding. It was just previously called end-of-life criteria.
Yeah, and if I may add, I think it's certainly something that would be valid methodologically. I think when you look at this specific patient population, we're talking about a subset of metastatic breast cancer, typically affecting women younger than 60 years of age, who on average have 18 months of life remaining, and the algorithm is declaring that as a medium severity, and we believe therefore the algorithm must be broken to reach that conclusion. When just to kind of show the scale of what the issue could be beyond this particular case, when we look into our own pipeline, the AstraZeneca pipeline, in the next 3 years we have 13 NICE submissions planned, which would have qualified for the end-of-life criteria, so the previous methodology which Haran mentioned. Based on our analysis right now, none of those 13 will qualify for the 1.7 severity modifier. So it's clear something needs to be done. Whether that's all metastatic cancers are deemed severe, I think that would be valid, but there are other changes to the qualification criteria which I mentioned, which also could be a short-term solution as well.
Thank you, Mr. Brocklehurst. This takes me on to my next question about the implications this has for research and development, because clearly by licensing drugs and NICE approving drugs, it provides an opportunity for building not only greater clinical evidence as to the effectiveness of drugs, but also can push the science to ensure that a future generation of drugs can be even more effective, prolong life longer, or indeed provide a curative effect in the future, which is obviously what we long and hope to see. What are the implications for science in this new mechanism for drug approval? We'll start with you and then.
Thank you. It's a really important question. Thank you for raising it. AstraZeneca is the largest private R&D investor in the UK across any sector, so pharmaceuticals and beyond. We invest £2.5 billion per annum in the UK in R&D. We've got more than 70 clinical trials ongoing within the UK, which recognises the amazing science that we have within the country and the environment we have for doing, world-leading R&D here. That's great. In order to do that and continue doing that, standards of care need to represent the latest standards of care. And what we're concerned about is that without a methods change, standards of care in the UK could fall behind other countries. So if we take the case in hand, there are 16 other European countries where this medicine is already available in HER2-low metastatic breast cancer, one of which is just a few hours north from here in Scotland, as you know. We need to make sure that UK patients are able to benefit from the latest treatments, many of which would be researched within the United Kingdom, in order for standards of care to keep pace, and we're able to continue to do, science and world-leading R&D in the country.
Thank you, Chair.
Okay, is that all? All right, fine. Paul Bromfield?
Thanks very much, Chair. And I just want to be absolutely clear, not least for the subsequent part of the sessions with NICE, about the problem. I mean, is the problem the movement from the end-of-life modifier to the severity modifier? Is it what was described, I think, by the ABPI as the severity modifier being applied on a more conservative basis? And indeed, the NICE board noted that there was lower than expected use of the severity modifier, and that indicated the problem. Or is it, as you seem to have very clearly said to us, it's simply that metastatic disease is wrongly classified as medium rather than high? So I just want to be absolutely clear on the nub of the problem.
I think the two problems are essentially have the same core, which is that the thresholds for severity are being applied very, very conservatively. So as a result, most disease areas, as evidenced by the fact that only 2 out of 39 applications in the last 2 years have actually achieved high severity, most disease areas aren't even achieving that threshold of high severity, including metastatic diseases.
My only additional point, if I may, because I fully agree with that, there is an interim modifier as well of medium severity. That's also being underutilised versus what was originally envisioned by NICE as well. So it's not just a metastatic cancer problem, it's all diseases. So the medium severity modifier is essentially being utilised around half the amount that it was expected to have been by NICE.
Okay, that's helpful. So, given that you've identified the problem so clearly, what discussions have you had with NICE on that issue? Because clearly it's leaving England as an outlier in Europe. So what discussions have you had and what response has there been?
Yeah, so, I mean, the first thing is that obviously we submitted the Enhertu to NICE for assessment, and we've worked through in partnership with NICE through the methods to bring the case to resolution, and we wanted to be a constructive partner in that regard. We do see, by the way, an emerging trend where the number of appraisals that are being withdrawn or terminated and don't reach a conclusion has doubled in the last 3 years to 20%. So we wanted to make sure we were constructively submitting to give every chance of this reaching a positive conclusion. Medicines in the UK are made available typically with a confidential discount versus what's publicly available in terms of price. We already have a commercial agreement in place for other uses of this medicine, so there's a confidential discount in place. There's also a confidential discount in place in Scotland, which was deemed to be cost effective in this patient population. We've offered a further discount to that in this setting, which was deemed not cost effective under current methods because of the application of the medium severity modifier for these patients. So we feel we've really been constructive in the process and gone as far as we can, actually.
If I could just add to that, Mr. Bloomfield, when the severity modifier was originally consulted by NICE prior to it starting in 2022, all of the major cancer charities objected or at least challenged the idea of a severity modifier, and certainly the application of it in terms of how rigid or how conservative those thresholds could be applied. So that's on the record in terms of Cancer Research UK and many other charities, patient groups. On top of that, as David said, from the get-go, we've tried to work in partnership with NICE to both share our concerns around the potential application of the severity modifier in this particular indication, but also Enhertu, the product we're talking about, has had 2 successful NICE appraisals over the last 3 years. And it's important to note that we're not anti-NICE, we're just anti the particular method, the application of the methods as they currently stand, because they've disenfranchised a whole swathe of deserving patients.
Just on the issue of pricing, which you've highlighted there, and I appreciate you're not going to conduct negotiations publicly, but campaigners have said that that NICE, NHS England, and the pharmaceutical companies need to get together to sort this. That suggests there's a responsibility on all parts for movement. How does that play in terms of the space for movement for your companies, Mr. Maheson?
We're willing to engage with NICE as an alliance, as AstraZeneca and Daiichi Sankyo. What we need, though, is a commitment to re-look at the thresholds for the different bandwidths of severity modifier, and also to enter into a rapid review, which according to NICE's methodology, starts from next Wednesday and lasts for 4 months. So time is really, really short to create some sort of sense of short-term change for this particular indication. But also the question is broader than this. It's around NICE methodology and recognising all deserving diseases for patients within those disease segments that could be in a highly severe state.
You'd add, Mr. Brocklehurst?
I mean, just the only thing I would add, and I fully agree with that, is that the price that we offered would have been cost-effective under the old methods. The end-of-life methods would have been cost-effective had a 1.7 severity modifier been applied. So, it's absolutely correct to say that if the methods were to evolve so that they broaden the criteria, so severe diseases such as metastatic breast cancer are recognised as such by the severity modifiers, then I think then there's a pretty clear conversation to be had by all parties.
Thank you very much.
Yeah, Rachel, did you want to come in?
Yeah, I just wanted to come in for a quick question about your concern around this. Are you more concerned around the pipeline of medication which is awaiting appraisal than just Enhertu itself, in the light of the implications for other things in the pipeline, and therefore are you using this as some leverage to change the mechanism on this occasion by not renegotiating on your own costs, because you know that the implications for the pipeline could be so significant, and therefore you need this mechanism to change rather than the kind of the approval just of this one pharmaceutical product?
I can take that first.
Please.
There are 2,000 oncology products in the pipeline across pharma in general that are due to come to market, due to get a license in the next 3 to 5 years. That's a huge number of products. So in many ways, trastuzumab deruxtecan in HER2-low is just the tip of the iceberg. It's the canary in the coal mine in terms of what could happen in terms of non-appraisals or failed appraisals. So really this goes way beyond one company's individual pipeline or one particular product and one particular indication. It's an industry-wide issue.
So if I can just press further, knowing 2,000 products will be pressing into this space in oncology, pressing into this space, is that of greater significance than Enhertu itself?
Absolutely.
Okay, that's interesting. Thank you.
Yeah, no, good clarification. James?
Yeah, just actually building on what Rachel Maskell was asking. So in terms of you talk about 2,000 oncology products. We've talked about this, Mr. Brocklehurst, 13 drugs in the pipeline. If the NICE criteria that we've been discussing were not to change, and it was to stay as it is today, what do you think the implications are for your business?
So, I mean, if I may answer that, thank you for the question. I think it's clear, like I said, that there's 13 NICE submissions that would have got the end-of-life criteria. There's many more actually planned. And it's, we have concerns that we're going to be unable, as Haran said, to be able to secure usage of these medicines for the patients that need them. Ultimately, we're pushing the boundaries of science to develop new medicines. The medicines we're bringing forward, we bring forward because they're going to extend life and maybe one day help to eliminate cancer as a cause of death. So that's why we exist as a company, and that's what enables us to continue the reinvestment in R&D. And yeah, this is an issue that needs to be solved for the 1,000 HER2 low breast cancer patients that are not getting standard treatment, that 16 other countries are getting, and for the many other new medicines that are going to come through from AstraZeneca, from the Daiichi Sankyo alliance, from other sources, from academia.
Because this is a global market, right? So is there anything that we can learn, because you're describing other jurisdictions have allowed this particular drug, have approved it. What can we learn from those jurisdictions?
Please.
Probably the nearest analogies are markets that have what we call cost-effectiveness thresholds, like the UK, like NICE. So Scotland, for example, the SMC has a similar system. Other countries like the Netherlands, Norway, Canada all have vaguely similar systems, broadly similar systems. And in all of them, they have a broader definition of severity. That's the key thing. And by having a more liberal, more broader definition of severity, it means that the value of the treatment and the value of the survival within that treatment is properly recognised.
Okay, thank you, Chair.
Okay, and just sort of, you say it's why you exist as a company, David. I mean, you exist as a company, of course, to make profit for your shareholders. I mean, that is why you exist as a company, right? You do good things as a result of being a successful company. But I mean, there's quite a big increase in the salary and bonus package for your chief executive recently, which hit a lot of headlines. A lot of people struggling to make ends meet, battling cancer right now, might think, well, when your chief executive's on a remuneration of a maximum of £18.7 million, you see how that jars a bit? Is that unfair?
So, I mean, thank you for the question. I feel actually, it doesn't determine, that particular topic doesn't have any determination on whether a disease is classified as, medium severity or high severity. I'm proud actually that I work for a company that, is successful and and has the ability, because of the profit it makes, the shareholders give us essentially the permission to invest 10 billion a year in research and development. Like I said, a quarter of that is in the UK. So, our success is what enables us to continue to reinvest, and that's the fundamental premise of the point
I make, I appreciate, of course, it doesn't impact the severity modifier, but my point is that, you could argue that success allows you to be more generous in the way that you make this drug available to what is a relatively small number of patients in the case of Enhertu through the NHS. Discuss.
Yeah, and I understand the question, and I thank you for it. And I would just essentially reconfirm that we feel we have already gone a long way and been quite generous in what we've already put on the table.
That's what I was trying to get.
It's lower than what's already deemed cost effective in Scotland. It's lower than what the NHS is currently paying for other uses of this medicine.
Sure. And then just finally, you sort of touched on this a bit with Rachel Maskell about thinking about our work and our report, the wider possible impact of these decisions on pharmaceutical companies looking to launch in England. What would you say on that score to ministers?
I think one of the statistics that David mentioned at the beginning was that around 20% of medicines actually haven't been launched that have been launched in other markets, haven't been launched in the UK. And quite often that is because of the perception of a prohibitive funding environment.
Yeah.
And so I could see that figure at least staying stable, if not growing, because companies have to make decisions around investment and around launching.
Yeah.
So it is a really pressing issue that we want to get right.
David?
No, I fully agree, and we've been able to invest heavily in R&D in this country, specifically because of the quality of the science that exists here, because it's obviously a home country for AstraZeneca, but it is, as I think you've recognised, a really competitive global market, and we would like to see the evolution to the methods so that the products of the R&D will become available to UK patients that, you know, deserve them.
Yeah. Okay, listen, thank you very much. David Brocklehurst from AZ and Haran Maheson from Daiichi Sankyo UK. Thanks for giving evidence. We'll mute the mics and make a switch. So if you could exit stage right, then we'll bring in our second panel. Thanks for your time. On Monday, which is just heartbreaking. I just wanted to give you a chance to say your memory of Chris.
Well, I mean, I wouldn't know where to start, really. She was such a fabulous, inspiring, energetic, someone who was so full of life, and I think it's really hard to believe that she's no longer with us. And she was, absolutely incredible in the way that she took her diagnosis of incurable secondary breast cancer at such a young age and started the charity Copperfield, which was all about raising awareness and the need to check your chest. That was her message. So I think if we would all in tribute to her, just remember to continue to be breast aware and think about her family and her friends who will be missing her very sorely at the moment. And it's been a privilege for Breast Cancer Now to work with Copperfield on so many campaigns, and we'll continue to do so.
Well said. I would just add to that shortly after I was elected, when I was chairing the all-party group on breast cancer when we first met, and I met Chris and I asked her if she'd come to Winchester and speak to some children in secondary school about check your boobs, and she said yes, but only if we can do all 3 secondary schools in one morning, which was exhausting for anybody, and we did, and we went to King's, Westgate and Henry Beaufort School in Winchester City Centre, and she spoke to school assemblies one after the other, and you could have heard a pin drop. And it was extraordinary the way she held that room. So R.I.P. Chris, and best wishes to Maria, her twin, who, the family find it very difficult today, which sort of is why we're here, right? And we're talking about Enhertu. Why is it such a promising treatment for women with HER2 low secondary breast cancer? And just explain to people what specifically how lethal HER2 metastatic breast cancer is.
Yeah, I think it's true. We've already heard today that in theory this is affects a small number of people, women about 1,000. But what we need to remember is that these are women living with incurable secondary breast cancer who have, who really do not have long to live, and Enhertu can offer an additional around about 6.5 months of life. For some it could be longer, and so that makes a huge difference to somebody. The opportunity to stay around for really important life events, maybe see your children make it to nursery school or secondary school. These kind of life events are really important, creating those memories for loved ones, and also having some hope for the future. And we know at Breast Cancer Now, we're hearing from women with low HER2 breast cancer who are absolutely devastated about this news, this result. They were holding out for this next line of treatment, and it's the delay for them. For some women, it will mean that they will lose their life, and it's so hard for people to hear that, and to hear today that the severity modifier, which as a charity, we're keen to influence policy in a really responsible way. We're very supportive of the work that NICE does. It's a vital part of our health system, but the change from the severity to the severity modifier from the end of life criteria, since 2017 we have seen 20 new breast cancer drugs coming online, which are really changing the future for people with incurable breast cancer. And so for these patients to be left out of that is really tough. It's heartbreaking.
Is it accurate to say this is the first breast cancer drug that hasn't made it?
For many years, I mean, there was I could call it a dry period when there weren't many new treatments coming through. But since 2017, as I say, we've had this real progress, and we're starting to see people. Chris, for example, she lived for 15 years with secondary breast cancer, really grueling treatment, but she did survive. And if we are going to realise our dream, which is that everyone diagnosed with breast cancer can live, and there is reason to hope for that in the future, but we're not going to achieve that if things like this keep holding us back. So this is a really important treatment. It doesn't it is there for a small number of people, but for those people it's everything, absolutely everything. And to think that this might be classified as a medium severe disease, it does feel quite,
I guess it's bad enough when we have conditions which, as a human race, we just can't touch because we're just not there yet on the science. But to have it on the shelf,
absolutely,
and just can't reach is heartbreaking. Yeah. Can I ask you about inequalities within the UK, which of course makes the not being able to reach the shelf even more frustrating, because some parts of the UK have a ladder that does reach it.
Yeah.
And so Scotland, of course, made a different decision. Wales and Northern Ireland would traditionally follow the recommendations of NICE, but I think there's a divergence going on, and I wonder if you could just tell us about that.
So it's available in Scotland. So obviously that's hard to understand for many people, that where you live in the UK will affect access to this life-extending treatment. And until recently, until this, really the decisions around the UK have been really quite similar. And for people in Wales and Northern Ireland, they will follow NICE, and so although at the moment through a limited access scheme, some patients in Northern Ireland will have access to Enhertu, that won't persist once the final decision from NICE comes, is reads across the UK. So yes, we do have a situation now where your postcode or your location will affect access, which is very tough.
Yeah. Okay, well, we'll come back with some, as you're obviously, I introduced you to the outgoing Chief Executive of BCN. We'll come back with some reflections just before we finish with you, as it'll be probably the last time you'll be before us. You'll be relieved to know. But we'll come back to that. But in the meantime, we'll continue on this subject. And Rachel Maskell is going to ask you a question.
Thank you. Obviously, we've just heard that this is the tip of the mountain top of the iceberg with regards to the supply of oncology drugs, which are waiting approval. But this is a specific drug which impacts on women. Are we seeing an inequality being built into the system which is impacting on women's health in particular? And I appreciate that men can also get breast cancer, but obviously predominantly women.
Well, I think when you look at the kind of the history of how the science has unfolded in breast cancer, because breast cancer is so common, over the years it's been possible to see quite a lot of research being done in the breast cancer space, and so there's been lots of exciting developments. what I'm worried about is actually we'll get to a point where people think, all right, breast cancer's done, we've done that. And yet there's all this potential still to come down the track where we could be world leading, but actually we're just kind of putting the anchors on here. So that's what I'm worried about. And I think, that there is a long way to go. We're still seeing 11,500 women dying of breast cancer a year, and about 100 men too. So there is and that number hasn't changed massively, although the number of women diagnosed with breast cancer has gone up, so survival rates are improving. Still, we've got that hard, that hard number that we've got to grapple with. So there is an inequality unfolding, and there's an opportunity to stop that in its tracks, and with this review that NICE are looking at for the severity modifier process.
I mean, certainly within our future cancer inquiry, we know that the world looks to the UK at developing its science, and this clearly will have a dumbing down impact of people wanting to invest in that science if they know that they can't get the approvals which are necessary. Is it just the severity modifier that needs to be reviewed, or are there other elements which could impact the decisions which NICE make? I mean, I'm certainly thinking about only 46% of approvals coming through, which clearly we're seeing much higher in other countries. So are there other factors within that, or is it just on the modifier?
Thinking about it from the patient perspective now, I would say the whole process needs to be speeded up, because there is that we've seen an enormous gap between licensing and drugs becoming accessible, and then you've got the implementation through the NHS, which always takes time. So the whole thing from a patient point of view needs to be speeded up, and that's got to be good for industry as well. I know NICE are part of that, and there are capacity issues as well. But it's the whole thing can take months and months and months. And if you're living with an incurable disease, you don't have that time. And it's got to be good for UK PLC to have that whole system really well oiled and meeting the needs of patients as quickly as possible.
You've mentioned pace, and that's certainly something that we've picked up within the processes. Are there anything within the mechanisms that you would want to see change as well for those approvals? Well,
I think obviously we need to look again at the severity modifier, which everyone's talked about. And we were concerned about it because of the effectiveness that we had seen of the end-of-life criteria for people with metastatic cancer. And, we'd seen those breast cancer drugs coming through the NICE process, getting into clinics and really changing lives. So where we've all talked for years about the benefits of personalised medicine, targeted treatment, and here they are coming along, and so we need to get them into clinics as quickly as possible for the benefit of patients. I'm not sure that's answered your question, actually.
It's helpful. I just want to kind of push this a bit further. The valuation of the QALY from the Treasury Green Book is at 70,000, and yet NICE is still working around 20,000 to 30,000. So I don't know if you've got any comments on why that is disproportionately downgraded in the pharmaceutical space.
I find it hard to understand why that feels so out of date.
1999.
Yeah, feels quite a long time ago. I've seen over the years the benefits of having a vibrant science environment where we do some of the best breast cancer research in the world in this country, and so I suppose I believe there is the benefits of helping to get the system to work really efficiently for patients with the NHS, speeding it up, making new treatments more accessible. clinical trials, I mean, that's a whole, you'll have thought about that, but, we need to improve access to clinical trials for patients across the UK, and we did used to be better at that, and so I worry about that too.
All right. Paul Blomfield, did you want to ask quickly?
I can just briefly follow up. I think anybody watching this session would find it difficult to understand why metastatic disease isn't seen as high severity, and would also think that it seems like a reasonably easy fix to get that reclassification. Now, you described yourself as an admirer of NICE. Why do you think, from your perspective, they've got this so wrong? And have you had any opportunity to engage with them in providing patient voice on the issue?
We will talk and do talk to anyone and everyone about this. We've been campaigning on access to new medicines for a long time, so we were very excited about the prospect of Enhertu becoming available. So we have spoken to NICE, we've played our part supporting patient advocates to be involved in the process, and we'll continue to do that to make sure the patient voice is heard. So I suppose, maybe you can ask NICE this, but they have a process that they have to stick to, and they, that's their kind of, their approach. They've got to do that, haven't they? So I suppose what we're hoping is that the review will come along quickly, and there'll be the opportunity to say, "Ooh, this isn't right. We'll think again," and we'll do that really quickly. And the scope of that review will be wide enough so that there's the opportunity to put this right really quickly, because we have to believe that they're doing the right thing for the NHS and for our health system, which is under a lot of pressure. So we've got to hope that that's going to happen really quickly and that they'll do the right thing.
Thank you. Yeah, James.
Just had one very brief question, Chair. Yes, just coming back to the issue about clinical trials, which you just alluded to. Are there any particular challenges around clinical trials for breast cancer drugs?
That's good. There are challenges for the system generally. So breast cancer services are particularly, they're under pressure in terms of time, and with new treatments coming through, it's the staffing requirements and so on. So that puts pressure on the system. There are also questions about how you can set up clinical trials. I'm not the expert, but having the standard of care in this country needs to keep pace with the rest of the world, the leading countries, in order to be an attractive place. But also you need to have access to enough people with enough different subtypes so that you can get critical mass for these kind of studies. But the patients really want to be a part of this and are really ready to get involved. So,
are there particular barriers in this country in comparison to other countries around the world?
I think infrastructure is a challenge. Joining up data is a challenge. Just research nurses, that's a challenge. I think probably all of those things, but none of that I think is insurmountable, because for me one of the most exciting and valuable things that our leading clinicians have to bring is that research leadership, which we have the most amazing clinical leaders in this country, and to be able to support them to crack some of the challenging questions in breast cancer is really, really important.
Thank you. Thank you, John.
Thanks. And don't, we heard just in the last panel, don't we have two excellent world-leading companies that have come up with an amazing product here. Just what would be what's the money shot for you in terms of when NICE take that seat where you're sitting now next, because nobody's questioning anyone's motives here. You know, everyone wants to do the best thing for people with breast cancer. What's the key question that you'd ask?
I think I would. What is the quickest and most and fairest mechanism for fixing this, this is so obviously a mistake? And so how can we do that with integrity? I think that's the important thing, because as you say, no one's questioning anyone's motives, and we need to have checks and balances in our system. Otherwise, you know, there lies ruin. So we have to find a practical way, a process way of dealing with this.
That's helpful. And then just reflections from you. You know, when we were in Singapore on this inquiry, somebody said to us, you know, our mission with cancer is to prevent it, and when we can't prevent it, we want to find it early, and when we find it, we want to treat it with precision. And I love that. What a mantra. If only we had a cancer strategy in this country that we could put that at the top of. But looking back at your time in this space, and I have a funny feeling that we won't see the last of you, Delyth, because we're all signed up for life to this one, aren't we? What are you optimistic about in the breast cancer space?
I'm optimistic about making the reality of stopping women dying of breast cancer in a really tangible way, because I've seen, you know, going back to the kind of 90s, the improvements that there have been since, you know, the new innovations around hormone treatments, around early diagnosis, new surgeries, all of that, and the introduction of targeted treatments. So all of that has made, we've seen real progress in survival rates for breast cancer. The really interesting challenge is that we then have now a situation where, we've heard people can't understand why it is that metastatic disease isn't recognised as being serious. So what's happened as a product of all this success is that there are now more women living with secondary breast cancer who feel that they're invisible, they don't have the same access to, say, clinical nurse specialists. They're worrying about that they're not going to get access to the future treatments that they should have, and they're not taken seriously, and they're not counted, because the data that is collected around metastatic breast cancer is really, it is incomplete. So service, at a service level, breast units, they don't know how many metastatic breast cancer patients they've got to look after, so how can they plan their service? So that sounds like a terrible picture, but I see that as someone who has their glass half full, that is a huge opportunity to make real change and improve the quality of life for all those people living with incurable breast cancer, to give them the support that they need and the certainty that they will be really well looked after. And then we will continue to take those steps one by one, like Enhertu, like access to new modern treatments coming through quickly. We'll continue to take all those steps, and then we will achieve that day when everyone diagnosed with breast cancer will live, and that will come. So I do feel very optimistic, but a lot of work to do.
Yeah. Okay, it's a lovely note to finish. Thank you for all you've done, and thank you for the people you've supported and the lives you've saved.
Thank you very much for having us today.
Not at all, thanks for coming. Please exit stage right, and then the final two guests will enter stage left. And as if by magic, the shopkeeper appeared, otherwise known as Dr. Sam Roberts, who's Chief Executive at NICE, which for those watching stands for the National Institute for Health and Care Excellence, and Helen Knight, who is the Director of Medicine's Evaluation at Nice. Great to see you both. Thanks very much, and thanks for giving up your time to sit and listen to the first two pair of guests that we've had. I suppose, should we start with Delyth's question? Well, let's start with Delyth's question, but let me just preamble it by saying, does this need fixing? Because Delyth's question was quite right. What is the quickest and fastest mechanism to fix this with integrity? So does it need fixing, and how do we do so?
Yes.
Dr. Roberts.
So I think we both believe that it does need fixing. The quickest fix is to reduce the price of the medicine, and that doesn't take months or weeks. It could be a matter of days for NICE to approve this medicine, because we agree it is in fact very effective, but it's not being offered at a value that is good value for the taxpayer in general. So that's the quickest fix. Why do we say that rather than a fundamental root and branch review of our methods? Or maybe let's just have a zoom out and then kind of zoom in.
Yeah.
We, like everybody in this room, understand the burden that cancer puts on society, on individuals, on families, and so we take very seriously our responsibility in providing access to these medicines. When we look over the last 10 years, 88% of the cancer medicines we've looked at, we've said yes. When we look at is the rate of time that we say yes getting worse since we implemented severity, the answer is no. When we look at the number of breast cancer medicines that we've looked at, 21 we've said yes to since 2018. Enhertu is the first that we've said no. In fact, a similar medicine, talazoparib, we said yes to. Similar disease, HER2 negative, metastatic breast cancer, we said yes because the value that was offered by the company was right. So I suppose the question for us is, we think this is an effective medicine. We absolutely think that patients should get it. Yeah. And the way to get it is to reduce the price at which it is being offered.
Okay. So the first panel said to us that, in the short term, what needs to happen is the qualification for the severity modifier entry, or the entry to the severity modifier, needs to change, and longer term there needs to be a review. You're saying that the qualification for entry to that is right, but the price is wrong.
So, yes, and let me explain some more. So there is no mechanism available for us just on a case-by-case basis to say, for this medicine we change the rules.
No, not a case-by-case, but is there a moment in time, a line in the sand, where you change the qualification criteria to the severity modifier? Is this that moment?
Yeah, so...
That's the nub of this, isn't it?
So that could be the nub of it. So in order to answer that question, we've been monitoring the use of severity modifier and would maybe like to correct some of the numbers that was presented earlier on.
Please do.
So I think the claim was that only 2 cancer medicines had received the highest severity. That's not true. It's been 5, 1 today. The claim was that we never say that metastatic cancer is severe. Again, not true. We have in a number of cases given that the highest weighting. So what we are currently doing is we're monitoring every single medicine that goes through. Did we say yes? At what level? If so, why not, etc.
Yep.
And in that monitoring, we're asking 2 questions, because I think you made this point when we started, is these are small numbers of medicine, so it's hard to draw conclusions on. But the first conclusion we can draw is, are committees not understanding the process and prosecuting it wrong or calculating it wrong? So we've had a detailed look at that, and that seems not to be the case. Committees are following the rules to the letter. Mm-hmm. So then the next question is the one you asked.
I said that, didn't I?
That's exactly what you said, yeah. So then the next question we asked is, are there big enough numbers here for us to draw conclusions on whether the rule is right or not right? And that's the process that we are busy monitoring at the moment, because, as you say, the numbers are small with this kind of thing, so you do get lots of variability. I'll stop there.
Yeah. So,
that's fine. Let's bring in Helen. By all means, Helen.
So obviously the introduction of the severity modifier came after a kind of a lengthy methods review that NICE undertook, and we published that in 2022. And I just wanted to remind everybody of the reason that we changed to a severity modifier. So, and this was during the methods review, we found evidence to say that people valued the health benefits in more severe diseases more highly than non-severe diseases.
Yeah.
Whereas our previous approach was just focused on what was an end-of-life criteria, which was very much limited to breast cancer, very much limited to cancer, and was only about extending life at the end of life. So there was support, the evidence was there for the severity modifier, and obviously we very carefully looked at how we would be able to implement that. And one of the benefits that we saw from moving to a severity modifier meant that we could attribute a higher weighting for benefits outside of cancer, so both non-cancer medicines and cancer medicines that didn't meet the end-of-life criteria actually would then start to have a severity modifier attributed to it. So we had a lot of careful considerations about how we could apply that, and we came up with the two-step, the 1.2 and the 1.7. And previously with end of life, we're hearing that this treatment would have got through with end of life, but we didn't have an automatic 1.7 modifier for end of life. So we did actually see over the years that we had end of life, not always was a maximum weight of 1.7 applied for end of life. So I think what I'm trying to say is it's not going to be as simple as just changing those modifiers. The fact that we have an exceptionality for severity is right. That's what the evidence said. What we don't know is how much more weight you should give in those circumstances. And that's where we have to be quite careful, because these are exceptional. What is happening in the NHS is actually every time we say yes and apply a severity modifier, we're actually displacing more health elsewhere in the system than we actually get for the treatment that we're looking at. So that's the really difficult and challenging decision that sits with NICE, is how do we allocate a fair approach to considering value for an NHS that has a limited budget.
Yeah, because resources are not infinite, and the customer here ultimately is NHS England, who we did invite to come be part of this discussion today on the stand. So I don't want to go all Bob Geldof here and bang the desk, but reviews, in the words of Mr. Geldof, people are dying now. We've got to try and get to a better place on this now, and that means meeting in the middle. I mean, that's what compromise ultimately is, right? Between you and the companies and the customer. We've got to get to a better place on this. Delyth's retiring. Help her out here.
Yeah, indeed. And I think it's fair to say I'm not breaking any confidences from either the company side or from Breast Cancer Now. We've absolutely tried to get around the table and find that middle ground, but the value proposition offered is still just too high. Okay. We absolutely stand ready if there's movements on it to take it back into our process in a matter of weeks. We don't need to wait.
There's no door closed here. There's
absolutely
no process done.
No.
And the company's quite right in their note to us. That as I said, there's no point in appealing it because the process has been followed correctly. We as MPs in our casework all the time, whether it comes to local housing cases or national policy issues, what we're interested in is whether the process, the law, has been applied correctly. It has here. Therefore, we look at the law and we look at the process, and that's what we're doing now. I'm going to bring in Rachel, if that's okay, and maybe could return to the quali point that you were just discussing with Baroness Morgan there. Rachel Maskell.
I will do. But first, I just want to put a proposition to you that this shouldn't be a case of either or. For people at the end of their life, this is their lifeline. Yeah. And surely looking at criteria which makes accommodation for metastasized cancers, those crucial pharmaceuticals within the modelling should be accommodated to ensure that is taken on board more than just the severity modifier is currently. Would you agree with that?
So I think what severity does is it values the length and quality of life, and so not just length, but length and quality. And so that allows us, exactly as Helen was saying, to sometimes apply it to cancers earlier in the pathway, where you get more health and long, less length, etc., and to non-cancer medicines. So I think if that is the aim, we currently do not have evidence to suggest that it is not fulfilling that broader aim. That doesn't mean in this specific case that it's not a really regrettable decision that we were surprised that we came to, because as we say, with equivalent medicines we've gotten to a yes without having the maximum severity for metastatic cancer. So I don't think it follows necessarily that because this decision was a no, the entire rule book is incorrect. If it has worked in other cases, I suppose that's our kind of claim.
If I can just explore a little bit further, this drug is approved in Scotland. Yeah. It's approved in 15 different countries. So why are we with criteria which marks it as not reaching the appropriate severity here in England, so that women are disproportionately affected here in England?
Yeah, so Scotland, as you rightly say, has the Scottish Medicines Consortium that looks at medicines, and they had a set of rules that they could apply to this that are not at our disposal. They're basically not in our rule book. We look very carefully at variability between England and Scotland, and so if you look at the last set of data on that, the FP-awake data, England is consistently ahead of Scotland, both in time to availability and number of cancer medicines available. So in aggregate, we're performing overall better. Again, this is a really regrettable case that we hope that we can resolve.
I do want to come into the pricing, but as we've heard as well from the pharmaceutical companies, that they're not just looking at Enhertu, they're looking at the pipeline here, perhaps 2,000 different drug applications. Clearly there will be a dumbing down effect on science if people are saying we can't get medicines to treatment. So obviously you'll understand those concerns, and it seems that there is gridlock over this and some leverage being applied in order to ensure that that pipeline isn't blocked in the way that it's being perceived around Enhertu. What scope have you got for negotiation to ensure that there can be confidence built within the pharmaceutical industry that they will be able to get their pharmaceuticals approved?
Yeah, so the way we look at this is we look at our performance. Is it getting worse or staying the same? And then we look at our performance relative to the rest of the world. How are we doing? So in terms of our performance, we have not seen an increase in the number of medicines that we say no to, and we've not, in fact, seen an increase in the number of medicines that were withdrawn, as our industry colleagues reported. Those have bumped along within the same kind of parameters for 10 years or so. So that's thing one. We see our performance on how often we say yes.
Something has changed in your criteria in 2022, so we need to look from that point rather than 10 years.
Yeah, I think the thing is, so absolutely, and we monitor it year on year. I think if you think about the number of medicines we look at, it's about 100 a year. So 2 on either side can kind of bump things up and down. So we roughly see things in a 10% window. On all medicines, we roughly say yes between 75 and 85% of the time, and over 10 years it's bumped in between those, and it continues to bump in between those. We've roughly had medicines pull out of the process between 15 and 25% of the time, and again, it tends to bump between those. So that's the first thing. We keep a kind of eagle eye on our performance. Is it degrading year on year? The second thing we keep a really eagle eye on is our performance relative to the rest of the world. Are we getting worse? And in terms of cancer medicines, the UK remains second in OECD countries in terms of cancer medicine launches, and we remain third on the time. Enhertu remains third on the time to launch, and that's actually improved. We were sixth, and we've got quite a bit faster. So, but yes, we do look at that data.
That's the point, clearly, that breast cancer now are pressing you on.
Yeah. And we concede that there is much more to do on speed and agility of the process.
So I'll just move on to a question about the QALY. I mean, the Treasury Green Book evaluation of the QALY is 70,000 compared to that set in 1999 for NICE, more money than ever is going into the NHS. What needs to be done to ensure that the value of the QALY keeps pace with the value of the economy and the market?
Yeah, so maybe Helen and I will do a double act on this, because the QALY the threshold that we use, you say the 20 to 30,000, it measures something different from what the Green Book measures. We're basically saying there's a fixed amount of money in the NHS. Every pound we put in can only be spent once, so it's displacing some care that somebody's already getting.
This is 25 years old.
Yes, and so what we look at, our threshold is based on what is the health being delivered and how much does it cost of the care that is already in the NHS. And so there's been widespread debate on that for many, many years about what is the health delivered, how do you value that? And that is something that is not NICE's sole prerogative to opine on. So traditionally, it's part of a negotiation every 5 years called the Voluntary Pricing and Access Agreements, which has recently been concluded, where, as you say, this was a topic of debate. The final conclusion was to leave it at the existing threshold.
So does the VPAG need to be revisited? Would you recommend?
Yeah, I mean, obviously that's the NICE aren't part of that voluntary scheme in terms of we're not a signatory, but we obviously are impacted by what we see. I mean, I think that there are, without knowing the exact value of health displaced, it's very, very difficult, and we feel that the £20,000 to £30,000 actually it does represent, it is and it has been working well.
It was overvaluated in 1999, was it?
Well, I think it's very difficult to kind of be able to say what, should it have kind of increased with inflation, because that's kind of not what we're using it for. We're talking about the health displaced, so we're talking about current health being displaced. In 99, it would have been health displaced in 99. So it's kind of a constant that we've taken over the years. And like we said, health provisions have changed over those years. So, kind of you're seeing improvements. So it doesn't necessarily mean that you should be increasing the cost per QALY threshold over time with inflation. And, there has been evidence to show that the opportunity cost is actually much lower than NICE's £20,000 to £30,000 that we currently have. There were academic estimates around £13,000 to £15,000 per QALY. So we feel that actually the £20,000 to £30,000 is reflective and works well for the types of products that we're evaluating. As we were saying, every decision that we take, if we were to increase that, then potentially we're actually overall removing more health than we're gaining for these new medicines.
But clearly not working for women wanting to see their life extended by a number of months.
This particular one, so we have recommended another treatment for metastatic breast cancer that received a 1.2 modifier recently. So it is only Enhertu that we've seen this challenge with.
Oh, did you want to ask a...
I do, although I'm conscious we're pursuing the same themes, but probably coming at it.
Okay. Repetition is not a crime in this place.
Discovered that. And I think it was an important point that the Chair made at the outset, that everybody recognises that you're trying to do the right thing. And that's a challenge, and I mean you were clearly distressed at the decision you've made in relation to Enhertu. But that in doing the right thing, there seemed to have been a broad welcome when you introduced the severity modifier. But we've heard that, and would you confirm that under the previous end-of-life modifier, Enhertu would probably have been approved? Is that the case?
So I think Helen touched on it. I'll start, and then you can take over. Is if the committee concluded that it got the maximum end of life, then that may well have been the case. What Helen was saying is the committee often did not conclude that, so we can't know. In the most optimistic scenario, I think is the scenario that industry were painting.
Yeah, I think Sam's covered.
So you've said that under the new system, other metastatic cancers have got the highest ratings. What's the factor here? I mean, is it, as you said in your opening remarks, price?
So I think the severity weightings are a combination of the number of years or indeed months that one lives and the quality of one's life during those years or months. So that's one part of the calculation. Then the second part is price. So on the previous metastatic breast cancer medicine, which we recommended in February, it was again given a 1.2 severity, so not the maximum, but the price was in a window where it was still considered to be cost effective.
Just in a general sense, I mean, clearly you have a really important job in ensuring value to the NHS. But when looking at costs, I mean, how far is that affected by the resources available? I mean, conscious that as a proportion of GDP, we spend far less on health in this country than most comparable countries. I mean, 9%, I think, from the latest figures that I saw, compared with 14% in the US. So how far is the resources available to the NHS a factor in you reaching your decisions?
So I'd say, and covering again, Helen, on a day-to-day basis, it isn't. And that's why we are so pedantic about having rules about how we make our assessments that are published, that we consult on, that are based on research, so that we can't be kind of buffeted around by the media about no ambulances or this, that, and the next thing. I think it's really an important part of our independence that everybody knows when they come to us, their medicine and their condition is going to be valued in exactly the same way as every other person's, but we are going to consider whether the length and the quality of life is greater, and we're going to pay more for that in a consistent way.
So, I guess that the impact, because I think Helen made the point that you have to recognise that if we're paying more for any particular drug, it has a consequence on the other services the NHS is able to deliver. Yeah. So the kind of resource available to the NHS must be a factor at play at some level in your decisions.
So it kind of the plain answer to your question is the available resource doesn't impact our decisions. So when we're actually looking at the clinical, how well a treatment works and is it value for the NHS, we take account of the current standard of care for that patient population. How much additional benefit do you get with the new treatment, and how much more expensive is it to deliver that treatment? And that's what's factored in. So the available resources within the system aren't factored into the committee's decision making on the value add of that specific treatment. And I think that it's important to be aware that, we're obviously aware that there may be health displace, or, the money's spent in one place can't be spent twice. But we don't definitively know what services or health or populations would be impacted by that decision.
Yeah.
Do we have one more go? Because I think we're edging towards an answer. What we're saying is, in the day-to-day running, in the individual decisions, we do not consider it because it's absolutely important that we have a consistent set of rules that is applied everywhere. However, as you say, in the creation of the rules, we create rules because we are a tax-funded health system that has got finite resource. So we know every single time we say yes, it is NICE says yes, it's pushing something else out. And I think it's that.
So if we spend 14% of GDP on health, the rules to provide consistency may be different.
It may be different, indeed.
Can I just pursue another point that Rachel's raised, which is about international comparisons? Now, clearly, we're an outlier on Enhertu, and we've heard this morning that the concerns about the application of this approach to other new cancer drugs is going to affect the appetite for investment in the UK and the availability of treatment for patients. Now, you quoted some current international comparisons, but we're at an early stage of your new approach. Are you confident that we're going to maintain our position going forward?
I think it's tricky to be entirely confident, because I think the net position on medicines access is a result of many factors, of which NICE severity is one small one. So we take our role in this very seriously, and so we, as I say, we monitor quarterly, annually, and then internationally we monitor as well. So we will absolutely know within the month, the quarter, the year, if things are starting to move downwards. But I think our industry colleagues would agree that we are part of a big system that gets medicines to patients. We've got a very important regulator, we've got a very important payer, we've got a very pressurized NHS. So I think we take our own role very seriously, but we also understand we're in some ways a small part of a much bigger system that affects global attractiveness of the UK.
Thank you very much.
Yeah, very interesting line of questioning. Good. James?
Just a quick one. Dr. Roberts, I think on the international comparisons, a general question, on the international comparisons, I think you said that we are third on time to launch for drugs. But then you said, but I recognise that we could get better on speed and agility.
Yeah.
How can we get better?
Well, do you want me to start? Yeah, exactly. So we, exactly like Baroness Morgan says, think every day that we delay is a day without a patient having that care. So we've been looking really closely at every single medicine that goes through us and at what are the main sources of delay. So the first job we did last year was figure out that about 1 in 5 of the medicines we see are actually pretty straightforward to evaluate, but we were giving them the full fat NICE appraisal, they just didn't need it. So those medicines now we put through a much more slimlined approach, and they are...
When did you implement those changes? Sorry?
So we implemented those last year. So in 23-24 we saw about 20% of medicines went through that, and about their average time from when MHRA said yes to we said yes was 38 days. Mm-hmm. So that was tick. So now we've got to look at what's happening with that other 80%. And so the biggest, for every medicine we look at what the biggest sources of delay are, and they are currently that we didn't know the medicine was coming in time, so we weren't notified. And we're doing lots of work with industry and the regulator and overseas regulators to rectify that. Or that industry actually said, sorry, we don't have the evidence available, could we delay it? There's been lots of... We always worry about NICE capacity. So 2 years ago, probably about 20% of, not probably, exactly, 20% of NICE appraisals were delayed because we didn't have capacity. Last year it was...
When you say capacity, you mean people?
Oh, sorry, 20% of yes, like
it was,
NICE people.
It was kind of resourced to be able to deliver the
Is that mainly people?
That's
It includes nice staff, committee time, other people that are involved in the evaluation.
But having said that, we've just seen our end-of-year numbers for 23-24, and the result of NICE capacity has led to 0 delays. So we've actually dealt with our internal staff issues, and we're fully staffed and kind of functioning. Now I think we need to get the handover between regulator, industry, etc., NHS England really slick so we can deal with that last 80%.
And how does that become slicker?
Well, we have 5 things we're doing this year. Do you want to take it?
Yeah, I just wanted, just before I do, I just wanted to comment on how important the information sharing bit is. So understanding when products are actually going through the regulatory process and how we can therefore align NICE's process to help with that. So as Sam said, the majority of delays that we've seen is because we didn't know they were coming. Right. So we've got important roles in terms of understanding that information in terms of timing, but also information, can we actually start to understand the types of technical data that's going through the regulatory process that can help NICE be prepared and better prepared for evaluating those treatments. So the first work stream that we're looking at is alignment of the timing of the NICE process with regulatory programmes. We're also benchmarking our current process to actually understand with more depth what's causing deviations from processes, that should take between 36 and 50 weeks. We're actually seeing topics take an average of longer than that. Right. And so what's causing those delays, and actually trying to have a better picture of what's happening so we can be able to respond to that.
So is this going to be implemented as a series of initiatives in the next year?
So in this business year, we're baselining
in this
everything.
Business year.
Yeah.
Right.
Yeah. And so what we want to have is a much better picture of what's happening in practice and what's driving those deviations from what we expect, to be able to help address what those issues are. We're also working closely with NHS England, who are updating their commercial framework, and we understand, obviously, the importance of kind of the commercial negotiations, but can that happen at a much earlier point in our process? We often see that we get to a committee meeting and we don't have those final commercial arrangements in place. Is there a way that we can actually get that done in advance so we can make positive recommendations at a first committee meeting? We're working with our external assessment groups, who are our academic groups who support the NICE process, to make sure that they're giving exactly what we need at the time that we need it, and quality checking their performance for the work they do for NICE. And we're also looking to shorten the back end of the process where appeals happen. The majority of our recommendations are positive, and therefore adding a 3 to 5 week end part of the process when we've actually reached a positive decision may not be required. So there's kind of a number of different factors that we're looking at this business year, and once we've collated all of that information, some of it will be able to change immediately, some of it, we need to kind of do a bit of a deeper dive to understand what we can do to rectify it.
Okay. Thank you, Chair.
Just finally, as we conclude our future cancer inquiry, is there anything that it sounds like in this instance it's not a ministerial decision. Clearly it's not a ministerial decision, but is there anything in terms of the process that you sit there and you think, yeah, we've got independence, we've sorted out internal staffing challenges, we've got the 5-point plan, but in terms of recommendations that we make to ministers about the operation of NICE and the environment in which you thrive, is there anything that you would like to put on the record?
Yes. So I think notwithstanding the fact that we have kind of poured over the medicines appraisal process today and looked at its strengths and weaknesses, it is often recognised internationally as a pretty good thing that England has done in NICE medicines access. I think if you look for the future of cancer at things such as early diagnosis, genomics, digital technologies, devices, we don't really have an equivalent process for those, where you have very clear reimbursements, very clear procurements. Okay. So I think there's whilst, yes, we could absolutely tinker with the NICE medicines at access, and we will continue to improve, there is a big gulf on things that could be helping people care for themselves at home, could be getting faster diagnosis, could be getting earlier diagnosis.
So as tech develops,
Yeah.
that opens a whole new
Yeah.
can of worms on devices and what are devices.
Digital technologies,
Digital.
genomic diagnostics.
Artificial intelligence technology.
Indeed.
Okay, I think Rachel just wanted to conclude.
Yeah, I just wanted to ask one last question. We clearly have heard what you believe the industry need to do now with regards to Enhertu. We've heard from breast cancer now about the longing for women to be able to access the medication that's needed. Can I just ask what steps you'll be taking when you leave the room to ensure that that hope that the women have can be fulfilled?
Yeah, so I think following today, we'll get back in touch with our industry colleagues and understand if perhaps a new deal is on the table, which can be quickly taken back to committee. And then to ensure that this is indeed an exception, not the rule, we'll continue to day by day monitor severity. And then once we've got a portfolio of severity medicines that have gone through the process that we can make a decision on, we will take a decision on whether the calculation needs to be modified or not.
All right, thank you. Suffice to say, you know us well enough to know that we will be watching very closely and continue our great interest in this. And to you from NICE and everyone else who's spoken this morning, please make this the continuation, not the end of the conversation. People's lives depend on it.
Indeed.
So, Helen Knight and Dr. Sam Roberts from NICE, thank you. That concludes the session. Order.
The proceeding has ended. The proceeding has ended. The proceeding has ended. The proceeding has ended.